All right. So we finished the anatomy. We finished the fluid and acid base. I need to change this one. We finished the fluid and the acid base. And today we're going to continue with we finished also the electrolytes. And today we're going to start from the renal physiology, okay? All right. As we said, this is a high yields for your MRCS exam. Kidney regulation of blood pressure. Merely, the first thing you need to understand for kidney regulation of the blood pressure is the renin angiotensin aldosterone system. Renin angiotensin aldosterone system, RAAS. Okay, I will explain in detail this system. However, we need to know what does trigger this system and how does it work. The mechanism, the renal blood flow, if you have a trigger which is decreasing renal blood flow for whatever reason, dehydration, hemorrhage, it doesn't matter what the reason is. You will have reduced glomerular filtration rate, and this will lead to increase in the renin secretion from the juxtaglomerular cell in the kidney. I will show you where is the juxtaglomerular cells in the kidney in a second. The word juxta means like close to. Juxta
العلامة
means close to. Glomerular.
العلامة يا علي،
Yes, Mustafa.
السهم the arrow that is before the ده
Yeah.
له أي معنى؟
Yeah. Reduction in renal blood
لا
flow.
ما
Sorry.
تحته اللي هو في سهم عادي ماشي اليمين يمين ده.
No, this like this a continuation, Mustafa. So you have
تمام
decreased
تمام.
renal blood flow will lead. This will lead this arrow mean lead. This will lead to increased glomerular filtration. If it confuses you now, so let's just take it off and make it easier. So decreased renal blood flow will lead to reduction in the glomerular filtration rate, which will leads to, and this leads to, okay, renin secreted from the juxtaglomerular cell. All right, the renin converts to angiotensinogen. So the renin converts angiotensinogen to angiotensin 1, and the angiotensinogen is produced from the liver. There's an image here. Let's just explain with the image. That will be easier for you. You have the kidney, which produces the renin. The liver produces the angiotensinogen. All right. The renin will convert the angiotensinogen to angiotensin 1. It will be secreted in the like circulating in the blood. The angiotensin 1 will convert by the ACE, angiotensin converting enzyme. The name says it all, angiotensin converting enzyme, from angiotensin 1 to angiotensin 2. Angiotensin 2 will go to the adrenal gland, specifically to zona glomerulosa, and enhance the production of the aldosterone. And then the aldosterone will be secreted in the body and has a specific effect in the kidney, causing vasoconstriction at the end. So this image is such a high yield image. Every single doctor should understand it in and out and memorize it. We'll come to the details in a second, okay? So after this image, you don't need to study this one. So this image tells you exactly how we reach the angiotensin 2, which will increase the production of the aldosterone. All right. Effect of
معلش
angiotensin. Hello? Yeah?
انت كنت بتشرح في الجكستا، كنت انا هوريكم صورة and then لما دكتور مصطفى صححك you drop that one.
صححني في شنو؟ in which in مصطفى دين صح؟
مش انه صححك، انه يعني انت لما غيرت leads to
No, I didn't change anything. I said I will show you the image of the juxtaglomerular, which I'm coming to, Ihsan. That's why we'll come to it. It's not like there was nothing wrong from the start to begin with. عشان مصطفى يصحح.
no
It was
I meant
the
انه
arrow for him was the arrow for Mustafa was not that clear. So there was an arrow here. We changed it from arrow to leads to make it just clear for everyone. There was no mistake to be
انا
correct.
فاهمة، انا
No,
بس
ما انت
قلت
قلت
كده.
يصححك. There was nothing
لا
wrong.
انا قلت ما قصدي.
Okay, fine. I will show you the juxtaglomerular cell. We'll come to it in a second. All right.
هي ما قصدها انه انا صححتك، ما في حاجه غلط.
Yeah,
بس
that's
انه
fine.
موضوع السهم.
Okay. Yeah. No, the juxtaglomerular cell, she asked about the juxtaglomerular cell, which I'm going to show you in the second. So this is a glomerulus, Ihsan. So when we say juxtaglomerular, that means the endothelial cells around here, close to the glomerular cell. This is the one that we mean. Okay. If you want another image for it, I'm going to show you here. Juxtaglomerular mean close to the glomerulus. Okay. Do you see here? This word, juxtaglomerular. Meaning this is a glomerulus. You know this convoluted tubule, this is a glomerular apparatus. Juxta mean close to. This is the endothelial cell. In the afferent, you have afferent and efferent arteriole. Okay, that's what we mean by juxtaglomerular cell. Okay, let's continue. Effect of angiotensin II. We will leave the question to the end, guys. Every single question will be at the end. The juxtaglomerular cell is a system that's close to the glomerulus. Effect of angiotensin II, systemic effect. This will cause vasoconstriction of the whole body. This will also lead to raise arterial blood pressure by causing vasoconstriction. If you cause vasoconstriction, this will increase the blood pressure. Clinical correlation, ACE inhibitor such as captopril and enalapril are used in the treatment of hypertension. This is the image. So you know exactly from what we just mentioned earlier, the effect and how the renin will change to angiotensin. The renin will change angiotensinogen to angiotensin 1, and then the angiotensin converting enzyme will change angiotensin 1 to angiotensin 2. If you see here, ACE inhibitors will prevent the formation from angiotensin 1 to angiotensin 2. And this will mean that there will be less aldosterone and there will be less angiotensin 2. And the effect of the angiotensin 2 is causes vasoconstriction. That means there will be less vasoconstriction and there will be less increase in the blood pressure. That's why we use the ACE inhibitors to control blood pressure. Okay. There's another type of medication, we call it ARBs, aldosterone receptors blockers, which the name says it all, aldosterone receptor blockers. They just block the aldosterone receptors, okay? They just block the aldosterone receptors, that's all. All right. This image is very self-explanatory and it's very easy to understand. All right, we spoke about the effect of the angiotensin 2 in the systemic effect, We have also renal effect. Angiotensin 2 constrict the efferent arteriole more than afferent arteriole. I'm going to show you the efferent arteriole and the afferent arteriole. I don't want Ihsan to get angry, so I'm just going to show it now. This is the afferent one, and this is the efferent one. This is the afferent arteriole. The word afferent means coming in, and efferent means leaving. So this is the afferent arteriole around here, and this is the efferent arterioles around here, okay? And this is the glomerulus, and I just showed you the image of juxtaglomerular mean. That's the endothelial cell close to the glomerulus. Juxta mean close, okay? All right. So in the renal effect of the angiotensin 2 is maintain or raise the glomerular filtration rate by causing vasoconstriction. Helps preserve renal filtration during low renal blood flow. So if there is renal blood flow, let's say your patient has what they call it, hypovolemia, and the blood supply coming here is low, okay? This will lead to activation of the juxtaglomerular apparatus and the renin will be reduced, renin. And then angiotensin 2 will come and causes vasoconstriction around here. When it does cause vasoconstriction around here, this will lead to increase the blood pressure around the whole glomerulus. And by increasing the hydrostatic blood pressure around here, this means that the glomerular filtration rate will be higher. Okay, that's the main idea, to avoid any renal acute kidney injury. Maintains, that's what we mean by maintain or raise glomerular filtration rate. Helps preserve renal filtration during low renal blood flow. So when you have low renal blood flow, this will help you to maintain the renal filtration. I just explained it by causing vasoconstriction around here and increasing the blood pressure around the whole glomerulus. Okay. Exam. What do you need to your exam? Angiotensin II causes efferent constriction, meaning this is the afferent, as I said, coming, and this is the efferent. Angiotensin II causes constriction here. Very important. Okay. Sympathetic stimulation causes afferent constriction, which means around here. All right. Sympathetic nervous system and kidney. We said the general effect of the sympathetic stimulation causes vasoconstriction of the whole body, and this will lead to increase of the arterial blood pressure. Arterial blood pressure, as you know, equals cardiac output multiplied by total peripheral resistance. That's a very important equation. We're going to come to it when we speak about the cardiology. It's more relevant in the cardiology. All right. Renal effect, we're still speaking about the angiotensin II effects. Constrict the afferent arteriole more than the efferent. This will lead, Mustafa, this means leads to, okay? Don't confuse it like earlier. Decrease in renal blood flow. This will lead to also decreasing glomerular filtration rate, oliguria, and concentrated urine. Okay. Important clinical points for your exam. In your exam, they may present a patient, long story, he had medication, he has catheter, and they tell you his urine output or glomerular filtration rate or whatever, his output was 60. It was 60 the next day, 16 the next day, and now became 0. So he has no urine output. They will ask you what is the cause for that. They will put oliguria and block catheter. If there is sudden decrease in the urine output, that means it's a blocked catheter. If it's gradual, so the urine output was 1 liter, then became 900 ml, then became 800 ml, then became 70 ml, and it's gradual, that's possibly oliguria due to acute kidney injury or whatever. So this one of the important points I want you to understand from now. All right, kidney and erythropoietin. You know erythropoietin mechanism. Kidney secretes erythropoietin from the interstitial fibroblast cells. And the erythropoietin means stimulate it. What does it do? It does stimulate the bone marrow, and this will lead to increase the RBC production. All right, so secretion, interstitial fibroblast cells, EPO into the bloodstream, erythropoietin into the bloodstream, and it does stimulate bind to receptors on erythroid progenitor stem cells in the bone marrow, and this will lead to increase of RBC's production. Okay, why this important? Because those who have renal failure will have anemia due to reduction of erythropoietin. Okay, clinical chronic kidney disease, yeah, that's exactly what I meant, may cause normocytic, normochromic anemia due to erythropoietin production. In your exam, they will literally ask you about the type of the anemia they will have. So it's not just you need to memorize it's anemia. No, you need to know exactly what type of anemia those who have CKD will develop, which is normocytic, normochromic anemia. Okay, all right. So the renin is from the juxtaglomerular cells. Okay, which does mean the cells that's close to the glomerulus. The angiotensin converting enzyme usually in the endothelial cells of the lung capillaries. Angiotensin II is the strongest renin angiotensin aldosterone system vasoconstrictor. Aldosterone retains sodium and water. Angiotensin II constrict the efferent arteriole. Here, efferent. Sympathetic stimulation constrict the afferent arteriole. Here. CKD anemia due to decrease in the EPO, normocytic, normochromic anemia. The RBCs will be normal in size and in color. All right. Before we go to the next module, does anyone have any question for this one?
يبقى زعلت مالك من إحسان.
ما
Why
ما في
did
زعل.
you...
نو مصطفى. انا ما بزعل يا زلمه، ما بحب يزعلني.
لا you were a lot bit لما قالت لك مصطفى صحك أنا ما فهمتها. هي ما
لا لا ما
قصدها
هو
حاجة، هي قصدها بس هي داير تذكرك إنه أنت نسيت الجكسالجلوميرولر بس.
لا
فهمتها؟
لا ما انا what did I say? I said there is an image. I'm going to show you the image. مصطفى ما في تصحيح. The word تصحيح صححك is not correct. That's all what I said.
لا that I was confused about
If you want to correct something, that means there's something wrong, right? There was nothing wrong. It was an arrow that's not clear to you, and then I changed it from an arrow to the word leads.
yeah she doesn't mean إنه في حاجة غلط.
Yeah.
She was
Yeah.
فهمتها؟
Okay.
ممكن بس كده يعني هنا.
Okay. Let's continue. Fine. Next one is glomerular filtration rate. So we finished the kidney regulation of the blood pressure, and this is a glomerular filtration rate. Okay. Glomerular filtration rate, renal blood flow. So we have, look, I know the questions, what will it be? However, I just wanted to understand the difference between renal blood flow and glomerular filtration rate. Definition of the renal blood flow. Renal blood flow means the amount of blood reaching both kidney every minute. That's the renal blood flow. And it's self-explanatory. You have renal blood flow, and the meaning of its renal blood flow the same. Renal blood flow, renal blood flow. The amount of blood reaching both kidney every minute. The normal value of the renal blood flow is about 1.2 liters or 1,200 ml per minute. So every single minute, there's 1.2 liters of blood reaches your kidney. Okay? This is around 20% of the cardiac output. Why? Because the cardiac output is 5 liters and 1.2 liters is 20%. Okay? Blood distribution in the kidney, 98 of the blood goes to the renal cortex and 2% goes to the renal medulla. Okay, let me show you the renal cortex. Why is that? Because the renal cortex is the one that has most of the nephrons, and the renal cortex is the one that's responsible for the filtration. Do you see? The green one is the renal cortex, and this is the medulla. So 98% of the blood goes to the renal cortex. Okay? Let me just put it here. Let me just open it from here. So this is important. So 98 goes to the renal cortex and 2% goes to the renal medulla. Okay? Clinical importance. When arterial blood pressure decreases, for example, in shock, the medulla becomes ischemic first because it's normally receive very little blood. This can lead to papillary necrosis or acute renal failure. Why it does lead to acute renal failure? Because loop of hell, and you have a lot of loops, goes down to the medulla. So when the blood supply to the medulla decrease, that means even the tubules of nephron will be affected too. Okay, just put that in mind. All right, how do we measure the renal blood flow? Measure the renal blood flow using Para-Aminohippuric Acid, PHA. This is very important for your exam. Renal blood flow is measured via Para-Aminohippuric Acid. Para-Aminohippuric Acid is filtered, meaning from the glomulars it will filter It also secreted by the tubules. However, it does not is not reabsorbed, and that's why we use it. Because if you have a fluid or if you have something that is filtered coming through here and secreted, if you have part of it goes to the blood, it will be secreted by the endothelial here, and it's not reabsorbed completely. That will give you an estimation of the amount of blood coming from here and left around here, because you will accumulate every single molecule that came from here and left through here. There's none will be left through here. Why? Because every molecule coming from here will be filtered or secreted by this one and not reabsorbed. That's why we use it to measure the renal blood flow. Is that clear? Is the idea clear for you guys? Why we use why do we use para-aminohippuric acid? Mustafa, I want you to repeat it to me, please. Repeat it for me. Or anyone. Safwat.
I wrote
Yes.
for you to explain it again.
Okay. So how do we measure that the renal blood flow is 1.2 liters in a minute? We need to measure it using some material that can come out in the urine. Okay. We need a material or a substance that will come through here. It will be completely secreted by the glomerulus. It will be completely 100% filtered and secreted, meaning if there's amount of it came through the endothelium or whatever, it will be secreted by here. And when it's come to the tubules, it's not reabsorbed at all. If you have these three criterias or these three characteristic, that means you will be able to measure the random blood flow, to the renal blood flow. Do you understand? Give me a thumbs up if you understand it.
So it enters the Bismillah ar-Rahman ar-Rahim. It
Look.
enters the gastroglomerular cell. Right?
Look, باختصار.
Okay.
Let me explain in Arabic. All right. You want to measure how much of the blood coming through here. So
Yes.
basically, you need this to be like غربال. ما بتمتص أي حاجة. So you need a material that completely crosses this one. Okay? And then at the same time, it's not reabsorbed at all by this one. So if it completely crosses this one and it's not absorbed by this one, that means all what you put here will come down there. Simple idea.
ممتاز
You need
ممتاز.
a material that's completely filtered through the glomerulus and none of it is absorbed. That will tell you the amount of the blood came. Does that make sense? والله اكتر من كده انا ما أعرف. That's the maximum I can do. Okay. So you need a material that's complete. ده دي تكون زي الغربال، معناها شنو؟ ده لك حاجه completely filtered here and it's not absorbed from here. Okay. All right. All right. Definition. Now we're going to talk about the glomerular filtration rate. So we finished the renal blood flow, and now we're going to speak about the glomerular filtration rate. Glomerular filtration rate means the amount of glomerular filtrate formed by all nephron in both kidney every minute. Okay, so the renal blood flow is the amount of blood coming here. This is renal blood flow. The glomerular filtration rate is how much of fluid, meaning urine, will come through here every minute. That's the glomerular filtration rate. And that's the main idea of it. Okay? Measures of glomerular filtration rate. We use inulin. So if you want to just remember and you don't want to understand anything, just remember glomerular filtration rate, inulin. renal blood flow, para-aminohippuric acid. If you want to just memorize, okay? It's measure in simple words. It's measure how much fluid is filtered from blood into Bowman's capsule. Normal value about 125 ml per minute. 125 ml per minute. So think about it. You have 1.2 liters of blood coming to the kidney every minute. All right. The amount of fluid that will be filtered is 125 ml per minute. I have a question for you. If we produce 125 ml per minute here, does that mean every one of us produces like 600 ml of urine every 5 minutes؟ هل معنى الكلام ده انه اي واحد فينا بطلع 600 لتر 600 ml of urine every 5 minutes؟
I think some of it will be reabsorbed by the TBOs.
Exactly, yes, Ahmed Ibrahim. Fantastic. Yeah, that's what I like. Yes. You won't produce 125 ml. The majority of it will be reabsorbed again. So when the fluid comes around here, these cells, the proximal convoluted and lobe of Henle and all the endothelial cell will reabsorb the fluids and the electrolytes. Okay. We said the measure. Inulin is filtered only, not secreted, not reabsorbed. So if it was reabsorbed here, that means the reading that you will have will not be accurate, because you want the inulin to be secreted and not reabsorbed in order for you to measure the glomerular filtration rate. اي انيولين دخل من هنا المفروض تقدر تقبضه هنا عشان تقدر تحكم على الفلتريشن ريت. ليه؟ لانه لو كانت الخلايا دي بتمتصه معناته حيكون عندك قيمه مفقوده، عندك قروش دخلت بجاي، عشان تقيسها بجاي المفروض ما يكون في اي حرامي يقدر يشيل القروش دي. لو في حرامي شال معناها حديك قراءات غلط. عشان كده you want a substance that does not reabsorb here. Okay, so this is the characteristic of inulin: filtered only, not secreted, not reabsorbed. If there's inulin produced in the body and it doesn't, there's no inulin produced in the body and it's secreted through here, that will affect your result too. Okay, all right. Is exam comparison. This is very important for your exam. The difference between renal blood flow and glomerular filtration rate. Okay, you have the definition here, the definition here. Why the exam will be, what substance will we use? For renal blood flow we use, I want someone to open his mic and say it quickly. For renal blood flow we use
Para-Aminohippuric Acid.
and for glomerular filtration rate we use
Allanil.
inulin. Okay, that's the most important part. You can read this message later on. If you have 20 minutes and your exam is tomorrow, kidney receives 20% of cardiac output, which is 1.2 liter. Cortex receive most of the blood flow, which is 98. We said it specifically 98% of the blood flow. Medulla is vulnerable during shock. Why? Because there's low blood supply to it, just 2%. But this is the exam. Okay, this is the exam area. Para-aminohippuric acid, best for estimating renal blood flow. Inulin, gold standard for glomerular filtration rate. Renal blood flow is much higher than glomerular filtration rate because renal blood flow is 1.2 liter. 1.2 liter. Okay, and the glomerular filtration rate is just 125 ml. Glomerular filtration rate is 125 ml, which means 1.025 liter. Okay, normal filtration fraction. So normal filtration fraction, don't worry about it, very complicated equation, doesn't come to your exam. Angiotensin II preferred constrict the efferent arteriole, and sympathetic stimulation constrict the afferent arteriole, as I showed you in the image. Do you have any question regarding this second lesson? glomerular filtration rate. All right, let's move to the next. I'm gonna do my best to be a bit more quick. I don't wanna. All right, the proximal convoluted tubule. This is the proximal convoluted tubule. Okay, you have afferent and efferent. All right. Okay, let me just proximal convoluted tubules. This more clear. Fine. Main function of proximal convoluted tubule. The proximal convoluted tubule is the major site of reabsorption in the nephron. It absorbs glucose, amino acid, sodium, water, and bicarbonate. Normally absent in urine. So this is a substance that we don't usually see in urine. If you see any of this in the urine, that means there's something wrong. Okay. Red blood cells, not filtered. Why? Because they are large in size. Proteins also not filtered because they are large in size and also they are negative. So when you have protein cells which are negative and endothelial cells which is negative, negative with negative, like they separate. All right. Glucose and amino acid normally completely reabsorbed in the proximal convoluted tubules. So the glucose and amino acid will be filtered here in Bowman's capsule. However, all of it will be reabsorbed in the proximal convoluted tubules. So you won't see it in the urine because this is the way the urine comes from. Around here, the secretion of the urine. Okay. All right. Normal completely reabsorbed in the proximal convoluted tubule. Glucose reabsorption, important point. Glucose is reabsorbed only in the proximal convoluted tubule. Reason, the sodium glucose co-transporters SGLT, and you know we have 1, 2, 3, 4, and 5. 1, 2, 3, 4 are found mainly in this segment. So SGLT is mainly found in the proximal convoluted tubule. That's why the glucose is absorbed around that area. All right. Transport maximum, there's a concept called transport maximum, meaning glucose appears in the urine when the filtered glucose load is more than transport maximum of the SLGT. This occurs in diabetes mellitus or in glycosuria, and this will result in glycosuria, glucose in urine. Think about it. You have glucose filtered every single second, and you have SLGT and receptors absorbing it. Okay? If the glucose that's secreted or filtered is too much more than the rate of the absorption, that means some of it will escape the proximal convoluted tubule. So you have glucose every single second leaving from the glomerulus here, goes to Bowman's capsule here. However, when it does come here, there is SLGT receptors here will absorb it. However, if the sugar or glucose coming too much and fast, that means some of it will escape the proximal convoluted tubule. And if it escapes the proximal convoluted tubule, it will not be absorbed anywhere else. Why? Because we don't have a reception to absorb it. Is that clear? Just put thumbs up if you understand what I just mentioned. All right. Fantastic. Main function of proximal convoluted tubules, we mentioned that. We mentioned what's normally absent in the urine. And I just explained the transport maximum for you. All right, quick pathology. Nephrotic syndrome, main feature, there will be heavy proteinuria, hypoalbuminemia, edema. Mechanism of edema. Loss of albumin in the urine leads to decrease in the plasma oncotic pressure. The fluid moves from the blood vessel to the interstitial space, which is the definition of edema, as I told you before. Here, site of action of diuretics in kidney. I think we have another image for it. However, this is very high yield from a physiology point of view for so many reasons. Okay, I will focus on the most important points. However, you need to review all this image, all of it. Loop diuretics is around here, loop diuretics, like furosemide. Why we call it loop of diuretic? Because they work at loop of Henle. Here, that's loop of Henle. Okay. Site of action, thick ascending loop of Henle. You have thin and thick ascending. This is the thick ascending. Mechanism, very important. Block sodium, potassium, 2Cl chloride transporter at the luminal border. This will lead to loss of sodium, chloride, potassium, and H+. Losing of sodium will lead to hyponatremia. Losing of chlor will lead to hypochloremia, hypokalemia. A loss of H+ will lead to metabolic alkalosis. I mentioned we explained the metabolic alkalosis from A to Z. Calcium reabsorb, and it also lead to calcium reabsorption, which may lead to decreasing calcium reabsorption, and this may lead to hypocalcemia. So all of this is very high yield for loop diuretics. Okay, very important. All right, thiazide diuretics. Site of action, they act in the distal convoluted tubules. Mechanism, block sodium chloride co-transporter at the luminal border here. This will lead to loss of sodium, obviously. The main idea, we are losing the sodium, and the water follows the sodium, as you know. When you lose the sodium and the water follows the sodium, that means you're going to lose a lot of water and a lot of sodium, and that's the effect of diuresis that you want. You want your patient to lose fluid. If your patient has heart failure or whatever, the main idea, you want to allow the fluid to leave the body. That's the main issue. If you can see, both the loop diuretics and the thiazide, both of them may lead to metabolic alkalosis. However, the difference between the thiazide and the loop diuretic, the thiazide increase calcium reabsorption. Okay? Increase calcium reabsorption. Which may lead to hypercalcemia. So if you have a patient who has hyponatremia, hypochloremia, hypokalemia, and metabolic alkalosis, and they tell you this, the calcium is high, they may ask you what diuretic does he has. What diuretic does he or she take? Is it loop diuretics or is it thiazide? The answer for that question is thiazide, because the calcium is high. Do you understand why this is important? All right. Potassium-sparing diuretics like spironolactone and amiloride. Site of action, collecting tubules here. Mechanism, spironolactone blocks aldosterone action. So spironolactone blocks aldosterone action. Amiloride, direct epithelial sodium channel blocker. So the aldosterone work on this channel. The spironolactone blocks aldosterone from reaching the channel. However, the amiloride blocks the channel directly. That's the difference between them. And we call both of them potassium-sparing diuretics because thiazide and loop diuretics, both of them causes hypokalemia by losing the potassium. However, this one does not cause hypokalemia, meaning that your patient your patient will not suffer hypokalemia. Okay, that's why we call it potassium sparing diuretics. They spare the potassium, they leave the potassium alone, they don't touch it. All right. Why loop and thiazide cause metabolic alkalosis? I explained that. And why thiazide causes hyperkalemia? All right. Thiazide increase calcium reabsorption from kidney into the blood. Why loop diuretic causes hypokalemia? I also explained that. All right. Easy comparison. So this is such massive, very high yield. All right. Comparison of the loop diuretics. Think about it. This is more details, and this is a simple table for you just to memorize. Okay. The effect of each one. All right. I'm gonna mention a couple of drug interactions that are very important for your exam, and they may literally give you the numbers. All right. So there's terminology that the pharmaceutical companies, or while you are dealing with the patient, you may hear about. Okay. Synergism. Synergism meaning you may have a drug and you add another drug to it. The effect, instead of 1 plus 1 equal 2, it will be 1 plus 1 equal 3. Two drugs potentiate each other. So if you have a patient with thiazide and you give, which is diuretics, and you give him furosemide, the effect will not be double. The effect may be triple. That's the word synergism. All right. Additive effect. Additive effect mean 1 plus 1 equal 2. If you combine effect, this will equal the sum of the effect of the two drugs. For example, if you have a patient with pain and you give him opioid like codeine or morphine, and also non-opioid like paracetamol or non-steroidal anti-inflammatory, the effect is 1 plus 1 equal 2. All right. Potentiate. Potentiate meaning one drug without effect increase the effect of another. So you give one drug, all right? However, when you add another drug, the effect will be 2. One drug without the effect increase effect of another. Example, probenecid and penicillin. The effect of probenecid and penicillin will be double. Antagonism, 1 plus 1 equals 0. One drug blocks the effect of another drug. Obvious. If you have a patient with morphine toxicity and you give him naloxone, this will lead to the effect of morphine, especially the respiratory depression, to be reduced. All right. And what does morphine do from acid-base balance point of view? We already mentioned that yesterday or the day before. If you have morphine toxicity, what do you expect the acid-base balance to be?
Respiratory acidosis بيعمل acidosis.
Yes. Due to respiratory depression. All right. I also want you to understand the drug elimination by kidney, usually due to what we call half-life of the drug. The definition of half-life means the time needed to eliminate 50% of a drug. Total elimination is considered almost completely eliminated after 5-time half-life. So we said half-life mean 50% of the drug to be eliminated. So the first half-life mean 50% removed. Second half-life means 75% removed. Why? Because you have one drug, you took 50% of it, removed it, and then the 50% you divided it into two, meaning 25% also going to be removed. When you add the 25% to the 50%, that will be 75%. 3 half-life, that means 87.5 removed. Same idea. 75% already removed, you have 25%. When you split 25% by 2, this is 12.5. When you take 12.5 and you trash it out, that means you will add the 12.5 that you just trashed out now to the amount that's already eliminated from before. This will be 75%. Okay? Fourth half-life is 93.75 and fifth half-life is 97 removed. So we call this part total elimination. However, you cannot eliminate it completely from the body because it will be reduced. It will reach insignificant amount. However, when you remove 97% of a drug, we consider it completely eliminated. Okay, you still have 3% in the 3% in the body. However, we consider it removed completely. Do you understand? Okay. Ultra high yield, if your exam is tomorrow. Loop diuretic act on thick ascending loop. Thiazide act on distal convoluted tubules. Potassium-sparing diuretic act on collecting tubules. Loop diuretics lead to hypocalcemia. Thiazide lead to hypercalcemia. And how you can remember this one? I just changed this one to C. Thiazides. Okay? Both loop and thiazide can cause metabolic alkalosis. Spironolactone blocks aldosterone. Amloride blocks epithelial sodium channel. Drug elimination, FAF 5 half-life. Okay. If you have, let's ask a question. If you have a drug, the half-life of it is 8 hours. In how many hours it will be completely eliminated according to this? According to here. Let me put it for you. If you can answer, open your mic and answer.
40 hours.
40, yeah. Fantastic. Of 8 hours, it will be. Tell us, how did you reach the 40 hours?
We multiply the 8 hours by 5, which is 5 half-lives.
Exactly. 8 hours multiplied by 5 half-lives. And this is a definition of complete elimination, right? This will,
total elimination.
yeah, definition of total elimination. And this will equal 40 hours. Everybody understand, right? This might be a question in your exam. Okay, fantastic. So we moved. Okay, we're doing great. Hormone acting on kidneys. Okay, so I just want you to understand, remember, and know for your life and for your exam these hormones. We have vasopressin, which is antidiuretic hormone, secreted from the hypothalamus, mainly suprapubic nucleus. We'll come to that in a second. Stimulus for secretion when you have high plasma osmolarity or dehydration. Site of action, medullary collecting tubules. Main function, water reabsorption from collecting ducts. Helps from form concentrated urine. Think about it. Antidiuretic hormone. Antidiuretic hormone. That's all what you need to know. Antidiuretic hormone. It does prevent diuresis. It does prevent the water from leaving the body. Antidiuretic hormone. Okay? So it will reabsorb the water inside the tubules. So ADH increase water reabsorption, this will lead to concentrated urine. All right, this is the first hormone affects the kidneys. Second one, parathyroid hormone. Site of action, proximal convoluted tubules and distal convoluted tubules. Main action at the proximal convoluted tubules, this will lead to phosphate excretion in the proximal convoluted tubules. In the distal convoluted tubules, it will lead to calcium reabsorption. Hope this is very clear. All right. Okay. Parathyroid hormone increase serum calcium, raise serum calcium level. How? By demineralizing the bones. It will take you from the bone. It will take you from the bone. Okay. Formation of concentrated urine. Main idea, to produce concentrated urine, the kidney needs high solute concentrated in the medulla, low water content in the medulla. So, okay. So you have the tubules starting from the cortex here, going down to the medulla. When we mentioned, you know this tubule, lobe of Henle, most of it is located in the medulla, not in the cortex. Okay. Formation of concentrated urine, main idea. Okay. This creates high medullary osmolarity, which pulls water out of the collecting duct when ADH is present. I hope, let me just see if there's an image here. However, you will understand all of it by just one image. Let me just try. I wish if I can draw in this app, but unfortunately I cannot draw. Okay, let me just. All right.
ممكن ترسم لنا في ممكن ترسم في
Sabura.
السبورة.
Yeah, right. Okay, so look, Here is the cortex. Do you see? Here is the cortex. Here is outer medulla and here is inner medulla. This is the layers of the kidney. When we come to the endocrine, I will tell you in detail the cortex and then the medulla. However, I want you to know now, medulla is responsible for epinephrine, the catecholamines production, and the cortex is responsible for cortisol, aldosterone, and sex hormone. Okay. The medulla has most of the loop of Hill, and has collecting tubules. The outer medulla has a proximal and distal convoluting tubules. Okay. The glomerulus, obviously, here in the cortex. All right. Long story short, I don't want to complicate it. This medulla here has to have a very high osmolarity. The salt and the concentration of the salt here is very high. Why? Because you want to suck the water, for example, here, before the urine leave. You need to keep the medulla highly concentrated and highly osmotic to absorb any water coming from the urine here. The osmolality here, as you can see, is more than 120. That means here is very concentrated. Very, very concentrated to absorb the water. Okay? All right. You have medullary interstitium around here. You have the urea. Let me just open what we just mentioned. So, ADH, yeah. All right. How we reach that? How we can make the medulla very, very concentrated and absorbing the water? Countercurrent multiplier mechanism. That's the mechanism that we use. Countercurrent multiplier mechanism. It took me 2 days to understand it when I was studying it. Okay? And I don't think I will try to simplify it for you here. However, each one need to just go and read about it. It's very complicated. Occurs in the loop of Hill. Okay. Ascending loop of Hill, important properties, impermeable to water. So the ascending loop does not allow water to get in. Actively transport solute sodium and chlorine into the medulla. Result, medulla becomes highly concentrated. I hope this is clear. So the ascending loop of Hill here, as you can see, actively pushing NaCl and urea, and it doesn't allow water to come in. Do you see? You see the thick wall here? That's mean this picture is so nice. I need to take it. So this wall, do you see here? That's mean the water is not able to come in. So the thick ascending loop of Hill pushing NaCl outside. This will lead to the medulla have high NaCl concentration. باختصار المظلة حتكون مالحة. It's very salty because the ascending lobe of Hill keep pushing NaCl. All right. And the water is not able to come in. All right. If you can see here inside, this is the concentration. Do you see? Urea, 300, 700, 100, sodium. Do you see here? So if someone asks you, what is the most concentrated filtrate, you will say in the middle of lobe of Hill here and in the collecting tubules. Why is so concentrated here? Because it's going to leave now. It's going to become a urine. So this shouldn't be diluted. Okay. The urea will be very concentrated around here. The urine, I mean, or the filtrate. However, when it comes up, it becomes diluted. Why it become diluted? It was 120, 1200 here. It's become diluted because NaCl is completely pushed. So the sodium from here is pushed out. It will reach 700, it will reach 100, around here 100, and it will start to concentrate again just before leaving the body. How? Because of the effect of ADH. ADH working with it in the distal convoluted tubules and in the collecting tubules. The ADH will actively take the water, and this will lead to concentrated urine before it does leave the body. Okay, I'm just gonna try and make it simple like that. Role of ADH act on collecting duct and causes water reabsorption. Water move toward hyperosmolar medulla. Result will be concentrated urine. Okay, this is just summary how to follow it. Renal dialysis, indication for dialysis is in the vowel letter A, E, I, O, W. We put E first because it's more important. Electrolyte disturbance, severe hyperkalemia. If you have potassium more than 6.5, this is for E. A, acidosis, severe metabolic acidosis, pH more than 7, less than 7.2, I mean. I for ingestion, toxin or drug overdose. O for overload, fluid overload, not responding to treatment. W for uremia, example, uremic encephalopathy or uremic bleeding. Contraindication of iodinated IV contrast. So there's some cases that we don't. So if you're doing CT scan, you can ask for a contrast CT or non-contrast CT. Contrast CT means you will give some fluid to your body to contrast to your patient to contrast the blood, meaning it will be very obvious in the scan. Contrast CT. Okay, so all of this is contrast. Okay, and where do we get the contrast from? It will be coming through the artery. It will كأنه إشعاع حي في دمك يعني. That's the main idea. You want to see exactly what's going on by filling the artery. Okay, contrast CT. Let me show you contrast CT angio. That will be even more better. So look, in order for us to see all of these arteries, we need to fill them with contrast. That's the main idea. Okay, that's the contrast. All right. Not everyone can take the contrast. There's absolute contraindication. Severe allergy to iodinated contrast. Example, anaphylaxis, angioedema, or bronchospasm. Relative contraindication, meaning you may use it if needed. Previous mild contrast reaction. By mild, look, what's the difference between this reaction and this reaction? What's the difference between mild reaction and severe reaction? Severe reaction if the patient has anaphylaxis, angioedema, or bronchospasm. Mild reaction if the patient has some urticaria or nausea or vomiting. As long as your patient has no anaphylaxis, no angioedema, no bronchospasm, that's not a severe reaction. Dehydration, renal impairment if the GFR is less than 30, or heart failure. All right, your exam is tomorrow. You just have 1 minute. ADH act on collecting duct. BTH increase calcium reabsorption and phosphatic secretion. Ascending loop impermeable to water, pumps out solute. Hyperosmolar medulla is essential for concentrated urine. These are the dialysis indication in AEIO. We said A for acidosis, E for electrolyte disturbance, potassium more than 6.5, I for ingestion of toxin, O for overload, U for uremia. Severe contrast allergy is absolute contraindication. Renal impairment increase contrast nephropathy risk. It's not that high yield. The last sentence is very like common sense. Okay. Acute kidney injury. Let's finish with acute kidney injury and then we'll take break for 5 minutes before we continue. Acute kidney injury. Normal urine output in adult is 0.5 to 1 ml per kilogram per hour. Okay. 0.5 to 1 ml per kilogram per hour. In pediatric, 1 to 1.5 ml per kilogram per hour. AKI. What is AKI? If you have any of these, creatine rise by more than 26.5 micromollimole per liter within 48 hours, or creatine rise to more than 1.5 baseline within 7 days, or urine output less than 0.5 ml per kilogram per hour for more than 6 hours. Acute kidney injury could happen due to pre-renal causes, renal causes, or post-renal causes. Post-renal causes. Pre-renal causes, decreased circulating volume, shock, hemorrhage, and dehydration. Mechanism: reduced renal perforation, kidney remains structurally normal. However, kidney try to preserve the sodium and the water, so it will be concentrated. Okay, renal causes. prolonged pre-renal state, drugs, and toxin. Meaning, if you have a dehydration, okay, shock or hemorrhage or dehydration, and it continued for days and days, this may lead to renal causes. It become a renal cause. Drug and toxin, example, acute tubular necrosis. By acute tubular necrosis, we mean the you know, the endothelial cell of the tubule. So if it's proximal convoluted tubule or distal convoluted tubule, will literally become necrotic. Mechanism: direct renal parenchyma injury. Tubule lose ability to reabsorb sodium and concentrate urine. Post-renal causes: obstruction of urinary tract like stone, benign prostatic hyperplasia, and prostate cancer. Here, okay. This table is very important for your life and slightly for your exam. Differentiation between pre-renal and renal AKI. All right, pre-renal cause, the urine sodium will be less than 20 millimole per liter. Why? Because your patient is hydrated, right? Pre-renal causes mostly dehydration or hemorrhagic shock. So the kidney will try to suck as much of water as it can. That's why the urine will be very concentrated. Urine sodium will be less than 10 millimole per liter. Why? Because the kidney will suck the sodium inside to suck the water inside. This also explains why the specific gravity will be high, because as kidney retain water to preserve volume, meaning the gravity will be high because you have less water. Urine osmolality will be high, obviously. Urine to plasma osmolality will be more than 1 because the urine will be very, very concentrated. If you give fluid, they will be respond to the fluid challenge. If you give fluid, your patient will respond. Here is totally the opposite. Why? Because the renal cause, you lost the renal tubules action. You lost the cell, so they will not be able to absorb the sodium. That's why the sodium will be high. If the sodium is high, the water will follow the sodium. That means the specific gravity will be low. Same as for osmolality, same as for urine to plasma osmolality. And if you give fluid, there will be no response because the main problem was not that you are losing fluid. The main response that's the tubules, the main kidney is affected. Okay. All right. What is fluid challenge and how we do it? Fluid challenge, we give the patient 500 ml of Hartmann solution. Can be repeated again if no response or patient has postoperative oliguria. All right, non-steroidal anti-inflammatory drug. Important point. Non-steroidal can cause pre-renal failure. Mechanism. Non-steroidal anti-inflammatory drug. So look, I don't want you to be confused. Non-steroidal anti-inflammatory drug mainly causes renal failure. Okay? Renal acute kidney injury. We call it interstitial nephritis. That's the main pathology for non-steroidal anti-inflammatory. However, sometimes it may cause pre-renal. How? Non-steroidal anti-inflammatory drug decrease prostaglandin. When you decrease the prostaglandin, you decrease the renal perfusion. This will lead to reduced renal blood flow and pre-renal AKI. Okay. All right. We're doing great. Fantastic. Now we're going to tackle the pathology, however, the endocrinology. However, I will give you 5 minutes break and then we will start. Okay. Just 5 minutes and then we'll start again. السلام عليكم يا شباب. لو في زول قاعد رسل الجروب كلهم بدينا. we're gonna start.
عليكم السلام.
رسل يا مصطفى لو if you can please to the group كلهم. We started again.
يا دكتور
Yes.
تركني احنا يعني امتحاننا هو concerned بالسيرجري، لكن ليه مركزين على الفسيولوجي بتاع ال تحسوا الحياة دي المفروض تكون مع الباطنية أكتر، صح؟ عارف.
والله يس، لكن هم باعتبار انه بارت ايه ده حاجه زي البيزك كده، حاجه بيزك يعني، فهم انكم تكونوا متعلمين البيزك يعني، فهمت؟ دي النقطه الاساسيه.
I
ما
see I see.
لما تجي الامتحان بارت ايه ان شاء الله حيختلف تماما الكلام. لسه في باثولوجي وفي حاجات زي دي، لكن كده يعني هم دايرين ناس السيرجر يكونوا ما سطحين وما عارفين حاجه. ده زميل دي الفكره الثانيه، يا هو زي ما قلت لك انه بارت ايه ده ما بتقدر تحكم به يعني كده. بارت ايه ده باعتباره
فرشة
حاجه،
شاي.
ايوه حاجه بيزك، فهمت؟
تمام تمام.
طيب بسم الله. نواصل نعمل شير للبتاع للسكرين. طيب okay, pituitary gland we're going to continue. Pituitary gland we're going to continue from here. Pituitary gland, we call it the master gland because it produces a lot of hormone. It sits in the sella torsica. This is the sella torsica, and here this is the sella torsica. If someone asks you, or in the exam they ask you where the sella torsica is from, the answer is it's part of the sphenoid bone. Okay, and this is the sella torsica. You have the hypothalamus here, and you have anterior pituitary and posterior pituitary. Both of them act differently. The the anterior pituitary produces a lot of hormones. We're gonna come to them one by one, and the other one will produce a lot of the posterior pituitary just produce ADH and oxytocin. Okay. Although it's tiny in size, its influence is extensive. So it's we call it the master gland. The master gland. All right. So hypothalamus activate the pituitary, specifically the posterior one, target endocrine organ. This will lead to body response. Okay. So this is a pituitary anterior and posterior, and target endocrine organs, all of them, and then this will lead to body response. We'll come to this in detail. Don't worry. All right, and we'll start with the anterior pituitary. We call it adenohypophysis. Developed from the Rathke's pouch, an upward outgrowth from the roof of the primitive pharynx. Receive regulation through hypothalamo-pituitary portal system. So this is the Rathke's pouch here. Okay, this is the brain. This is where the foregut comes from, and this is where the heart come from. Okay. All right, produces and secrete. This is the anterior one. We're talking about the anterior one. Growth hormone, prolactin, thyroid stimulating hormone, adrenocorticotropic hormone, melanocyte stimulating hormone, luteinizing hormone, and follicle stimulating hormone. All of this coming from the anterior pituitary. Posterior pituitary develops from the infundibulum. Okay, this is the infundibulum part. Develop from the infundibulum downward extension from the floor of the forebrain. Does not synthesize hormone itself. So if they ask you true and false, and they said oxytocin is synthesized or whatever, I don't know how to say that word, from the posterior pituitary, the answer is wrong. It's just stored in the posterior. So in your exam in MRCS Part A, there may be a true or false question. They may ask you what of the following sentences are right, false, or right. So if they say the oxytocin is produced by posterior pituitary, that's wrong. It's not produced by posterior pituitary. is stored in the posterior pituitary. It's produced from the hypothalamus. The paraventricular nucleus produces the oxytocin, and the supraoptic nucleus produces the vasopressin, which also we call it antidiuretic hormone. This hormone travel along the hypothalamus-pituitary tract, where they are stored and later released from the posterior pituitary. Okay, we just mentioned both of them. All right. Now we're just gonna speak about very high yield disease called acromegaly. Acromegaly is a extensive secretion of growth hormone occurring after fusion of the epiphysis in adult, causing enlargement of bone, soft tissue, and internal organs. Most commonly caused by pituitary adenoma, somatotroph adenoma. Okay. Less common cause, ectopic, growth hormone releasing hormone secretion due to cancer or whatever, a rare growth hormone secreting tumors. Okay. Association. Growth hormone releasing hormone, this is not from the pituitary. All right. So if you have pituitary adenoma, that's acromegaly, which may lead to increasing growth hormone. Sometimes it will be from up high, from the hypothalamus. If the hypothalamus produces a lot of growth hormone releasing hormone, this also leads to acromegaly. Rare growth hormone secreting tumor. Association can occur as part of men type 1 syndrome. Men type 1, will come to that in details in the pathology, but I want you to remember, we have men. What's men stand for? What does men stand for? MEN.
Plasma.
What?
Multiple endocrine neoplasm.
Yes, multiple endocrine neoplasm. Fantastic. And in men 1, you will have pituitary, tumors, pancreas, and parathyroid. Clinical presentation, there will be big skull, enlarged lips, coarse facial feature, frontal bossing, bronchosthesia, and spare teeth. And this is, let me show you the image. This is the image and demonstration of acromegaly. Okay. You don't need to memorize most of them, but you need to understand, just like in order for you not to miss a diagnosis later on in your life or in your exam. They will give you a typical scenario of acromegaly. Okay, this is how the patient with acromegaly will present. How will you diagnose it? You will check for insulin growth factor 1, best screening investigation, and it will usually be elevated. Oral glucose suppression test, normal growth hormone level becomes suppressed when you give oral glucose. In acromegaly, growth hormone remains elevated. If you suspect pituitary, you may do MRI pituitary gland, detect pituitary adenoma, assess the size and the extension. You may say, why don't we start with MRI? Because sometimes, even if your patient has acromegaly, you won't be able to check it with just MRI because the gland size will be normal. That's why we start with the hormonal test before to the gland. Okay. Management. First line treatment, transsphenoidal surgery, removal of pituitary adenoma. When I was medical student, it never made sense for me that we're treating pituitary adenoma by removing all of it. Ihsan, why we treat such a tumor by removing all the pituitary gland? That never made sense to me. Can someone convince me? Pituitary gland is very important, right? How come we take it all off just because the patient has acromegaly? How come? Tell me.
I think بما انها بتعمل اصلا زياده في الجروث هرمون، ممكن تعمل زياده في هرمون ثانيه.
ممكن. طيب واحدة من الإجابات. The only thing إجابتك not bad. The only thing made sense to me إنه الإفكت بتاع الأكروميجالي is such a high effect. If you see here, firstly, it may lead to arthralgia, headache, enlarge of the hand and feet, coercing feature. Okay. changing the feed. It may also affect the heart. Okay, so if we came here, why do we remove the pituitary in acromegaly? Surgery is performed over the tumor adenoma on the pituitary gland. This primarily goes to stop and excess production of growth hormone. Ultimately reverse. There's another thing I want to tell you. So look, mass effect. Okay, you will take also a sample and send it to the lab. You may not need to take all the pituitary gland outside. And the third thing is the effect of the if your patient has acromegaly and you gave him somatostatin, usually will not be that effective, mainly. Okay, so it's sometimes not that effective. That's also one of the reasons why we don't use it as much. Let me just share the
يعني
screen.
لما نعالج لما نعالج الاكروميجالي يعني تاني الحاجات اللي الضخمه دي تاني بتصغر ولا شنو؟
لا it's not. It's gonna stay the same.
اوكي.
It's gonna stay the same. Imaging. MRI pituitary gland, detect pituitary adenoma, assess the size and the extension. Management. First line treatment, transsphenoidal surgery. Removal of pituitary adenoma. Medical treatment, which is usually not effective. Somatostatin and a log. So somatostatin reduce everything, like octreotide and lanetroid. Your main idea is you want to reduce the production of growth hormone. You may also give dopamine agonist, which has an effect of reducing the growth hormone, like caprolactone. You may also give growth hormone receptor antagonist, bigavosomant. You may also give radiotherapy used if surgery is unsuccessful. Consider when patient is not suitable for surgery. For whatever reason, old patient, he will not tolerate the anesthesia, then you can consider it at that time. Okay. So acromegaly is high yield. Yes.
المانجمنت تو ستوب ذا يعني عشان حالته ما تتطور اكثر صح؟
Yes, exactly, yeah. All right, thyroid gland. Thyroid gland, you need to know that how the thyroid hormone will be produced. You have the thyroid stimulating hormone, obviously, coming from the anterior pituitary, goes to thyroid follicle. In the thyroid follicle, you have colloid thyroglobulin. You have iodine, which will join tyrosine. This will form thyroglobulin. I want someone to give me the enzyme, the main enzyme in the formation of this one. Thyroglobulin to diiodotyrosine. What is the enzyme? It's called TBO. What does TBO stand for? TPO. Thyroid peroxidase. You need to remember this enzyme, very important, guys. Okay, thyroid peroxidase. Let me even change the image to an image that had the enzyme on it so you don't forget it. Peroxidase, do you see here? Okay. In your exam, the exam trick is not memorizing each disease separately. So, okay, when we come to the pathophysiology, obviously, your question here will be, they will give you lots of hormones and they will ask you what is the disease. Okay. Unlikely to ask you about the details of the physiology here. I just want you to know that colloid thyroxine with the tyrosine, the iodine will come inside the follicles. Thyroid peroxidase will provide dityrosine and monoiodotyrosine. If two diiodotyrosine came together, this will form thyroxine, meaning T4. Di mean 2. 2 plus 2 will form T4. And if one mono iodotyrosine came with one diiodotyrosine, this will give you triiodotyrosine, which is T3. T3 is the active form. T4 is the inactive form. All right. And T4 will become T3 in the peripheral tissue. Okay. All right. And propranolol, which is beta blocker, prevent formation of T4 to T3. We'll come to that later on. Your exam likely to come from this table. Let me show you the table this table. They will give you a scenario and they will tell you the hormones and they will ask you what is the diagnosis. Okay. Let me first explain these ones. So primary hypothyroidism, that means the issue is in the thyroid. The thyroid is not able to provide the thyroxine. That's the word primary hypothyroidism. If you have primary hypothyroidism, your T3 and T4 will be low. Why? Because the thyroid is not able to produce them from the start to begin with. When the T3 and T4 is low, your body, there will be no activation, no negative inhibition to the TSH. So the TSH will increase. Why will increase? Your body will try to compensate for the low T3 and T4 by producing more thyroid stimulating hormone. Okay? Mechanism, that's as I said, thyroid gland failure. Pituitary tries to stimulate the gland. As you know, the TSH is produced by pituitary, right? Thyroid stimulating hormone. So the pituitary will try to push hard for the thyroid to produce the T3 and T4 because they are already low. Your patient will present with fatigue, weight gain, cold intolerance, dry skin, constipation, and bradycardia. Give me thumbs up if you think this is clear for you. Fantastic. Where are the rest? الباقيين. مريم. إحسان شكلها زعلانة. لا طولت ما عملت لايك. Okay. Primary hyperthyroidism, meaning primary hyperthyroidism, meaning that this is the opposite of primary hypothyroidism. The thyroid gland is active more than it should be. Thyroid overactive. The pituitary, when the thyroid is active, the pituitary will reduce the supply to the TSH. Okay? The pituitary will reduce the supply to the TSH. Why? Because you have a lot of T3 and T4. What do you need TSH for? That's the primary hypothyroidism. Your patient will have weight loss, heat intolerance, meaning they will not tolerate the heat. There will be palpitation, tremor, anxiety, and menstrual disturbance. All right. Secondary hyperthyroidism, we mean the issue is in the pituitary. Secondary hyperthyroidism. Secondary hyperthyroidism. Secondary hyperthyroidism. The issue is in the pituitary. So the pituitary produces a lot of TSH. And because the pituitary is producing a lot of TSH, this will also activate the thyroid gland, and you will have a lot of T3 and T4. Okay? So the difference between this one and this one is very obvious. Here you have this is high, here also this is high. However, here the TSH is low. Why? Because there's no issue with the pituitary. Pituitary is working fine, and it reduces the supply of the thyroid. However, in this case, the issue is in the pituitary, and that's why the TSH is high. Symptoms of hyperthyroidism, goiter may be present. Okay. All right. Secondary hypothyroidism. By secondary hypothyroidism, the issue is in, when we say secondary, the issue is in the pituitary. So the pituitary produces less TSH than normal. This will lead to less T3 and T4. Pituitary failure, no TSH stimulation. Okay. All right. Subclinical hypothyroidism. The subclinical hypothyroidism, your patient TSH will be normal. Your patient T4 will be normal. Your T3 usually will be low. Raise TSH before T4 drops. So the TSH is high. However, the T4 is normal. Usually asymptomatic, may progress to overt hypothyroidism. So if you have a patient with, that's why we call it subclinical. That means your patient has no symptoms. That's why we call it subclinical, because there's no symptoms. Okay. So you have high TSH, normal T4, you need to be careful. And the subclinical hypothyroidism, meaning it's not still hypothyroidism. All right. Isolated T3 toxosis. TSH will be low. Why? Because T3 is high. However, T4 is normal. Okay? T3 is red, T4 is normal. Early hyperthyroidism pattern. Symptom of mild hyperthyroidism, you need to monitor T4. This is also very common in your exam, sick euthyroid syndrome. So I want you to focus here. They will be normal or low TSH. T3 will be low and T4 will be low. Okay? So normal or decreased TSH. This will be seen in severe illness, sepsis, surgery, trauma. Decreased or normal TSH, we said that already. Okay, and severe acute illness. Do not treat with thyroid hormone. This basically we call it ICU. This will happen in the ICU patient. So the sick euthyroid syndrome treatment is treating the underlying cause. Does your patient have sepsis, surgery, trauma? You treat the underlying cause. Your patient will have low T3 and low T4 plus normal or low TSH. Okay. Here, this is just the explanation of each one, and most of it is not that high yield. The high yield is this table. Okay. Just focus on this table, please. This table is very important. All right. T3 vs T4. T3 is more active. T4 is less active. Source, small amount made by thyroid, most of it made by conversion of T4 into tissue. Okay. And how you can prevent this conversion? You give propranolol. We'll come to that later on. Main hormone secreted by thyroid gland. Short half-life for T3, has a long half-life as 7 days. Why? Think about T4 as a reservoir, a storage for T3. Okay, this most of what you need to know about the physiology. Then we just bear with me 1 second. We're gonna tackle the parathyroid gland. Do you have any question till now? All right. Parathyroid gland, easy, not difficult. Calcium homeostasis hormones, parathyroid hormone, very important. It's a polypeptide hormone secreted from the chief cell of parathyroid hormone. This is very important. Chief cell. Okay. Half-life 10 minutes. Main function of parathyroid hormone, increase bone resorption, release calcium and phosphate into blood. Kidney, increase calcium reabsorption, decrease phosphate reabsorption, activate vitamin D. Intestine, indirectly increase calcium absorption through activation of vitamin D. The overall effect of it is increased serum calcium, decreased serum phosphate. Due to its short half-life, it can be used for intraoperative monitoring, checking, particularly during parathyroid surgery to assess the successful gland removal. Meaning, if you have a patient in theater and you took the parathyroid gland out, you can check intraoperatively after 10 minutes because we say the half-life of the parathyroid hormone is just 10 minutes. That's all what it means. All right, formation of vitamin D. In the skin, the cholesterol in the skin is converted by ultraviolet rays, which is a sunlight basically, into cholecalciferol vitamin D. In the liver, the cholecalciferol undergo hydrolyzation in the liver by 25 alpha hydroxylase. This will result in 25 hydroxy cholecalciferol. In the kidney, then this will go to the kidney. In the kidney, 25 hydroxycholecalciferol undergoes another hydroxylation in the kidney by 1 alpha hydroxylase. This will result in 125 dihydroxy. It became dihydroxy because you have the first hydroxy and now a second hydroxy. Dihydroxy cholecalciferol, which is active vitamin D. I told you before that sarcoidosis increases the calcium. How? The sarcoidosis increases the calcium through 1 alpha hydroxylase because the granuloma in the sarcoids will produce one. The granuloma in the sarcoidosis will produce 1 alpha hydroxylase, and 1 alpha hydroxylase will increase the vitamin D. Okay, let's continue. Fantastic. Okay, this image give you an idea of prime. When we say 1A, that means primary hyperparathyroidism. This means secondary hyperparathyroidism, and this means tertiary hyperparathyroidism. Okay, primary hyperparathyroidism. The issue is in the parathyroid. The parathyroid gland, if you remember in the anatomy, I showed you the parathyroid gland. I said we four parathyroid on the back of the thyroid gland. Parathyroid, paramedics, close to, similar to, okay? That's why the name came from parathyroid. It's 4 gland on the back, okay? The parathyroid hormone will be high because the gland is overproducing, obviously. The calcium will be high because the gland is بتنخر في البون, attacking the bone and producing calcium. The phosphate will be low because we said the parathyroid hormone decreases the phosphate. And I just told you in the previous lecture that the parathyroid increase the phosphatic secretion in the distal convoluted tubules. The patient will have normal kidney. Okay. Secondary hyperparathyroidism, there will be high parathyroid hormone. There will be hyperplasia, not just adenoma, in the parathyroid. Calcium will be normal or low, and phosphate will be high or normal. And why is that? Because your patient has chronic kidney disease. So your patient has chronic kidney disease. This will lead to parathyroid hyperplasia because your patient has chronic kidney disease and he has low calcium. Your body will overactivate the parathyroid for a long time, causing hyperplasia. This will lead to high PTH, and then this may be able to get to the calcium to the normal, or may not even be able to get calcium to the normal. The main idea, guys, because calcium is very important, we want to get it to the normal in a patient with chronic kidney disease. That's how your body thinks. Okay, so it will activate the parathyroid. Parathyroid will make the BTH very high, parathyroid hormone. However, we may succeed in bringing the calcium to normal, or we may fail, and in that case, the calcium will be on the lower side. Okay. All right. Tertiary hyperparathyroidism. There will be hyperplasia of the parathyroid. Parathyroid hormone will be high, calcium will be high, and phosphate will be low. Okay, so you cannot differentiate this one from this one. There's only one thing will differentiate it. The primary hyperparathyroidism has normal kidney. The tertiary, the patient had renal transplant, or the patient has chronic kidney disease for such a long time. Now it became autonomous. The adenoma became autonomous like hyperparathyroidism here. So the only difference from this one and from this one, this is normal kidney. It took me a lot of time to create this for you guys because it was not easy. Okay.
What's the meaning of the word autonomous? Autonomous.
Autonomous, yeah.
What is the meaning?
Or spontaneous. Acting spontaneously from itself. When I say Mustafa be autonomous, that means I want you to be like proactive, okay? Or act from within yourself. Okay?
So the kidney will be autonomous?
Not the kidney, the parathyroid. So
Uh,
here, because you have low calcium will activate the parathyroid, make hyperplasia, and the parathyroid will try to get the calcium to the normal, okay? In this case, because it's such a long time of activation, or if the patient had a renal transplant, the parathyroid will act exactly like adenoma. Do you see? Same as adenoma. The only difference that he is a normal kidney and he was no normal kidney. Okay. All right. Here, this is another image showing you the parathyroid hormone and vitamin D and what each one does. Okay. You can have a look at this image, very organized later on. You have 2 minutes. Your exam is tomorrow. I want you to remember 25 alpha hydroxylase is from the liver. 1 alpha hydroxylation is in the kidney. Calcitriol is the active form. Parathyroid hormone stimulate renal 1 alpha hydroxylase. Chronic kidney disease lead to decrease in 1 alpha hydroxylation, leads to decrease in active vitamin D, leads to hypocalcemia. Okay, fantastic. Adrenal gland. I told you we'll come to it later on when I was speaking about the cortex. So the adrenal gland are paired endocrine gland located on the superior balls of the kidney, as you know. The production of hormones that are important for metabolism, blood pressure, stress response, salt and water balance, and sexual development. This is also very important. Each adrenal gland has two parts, cortex and medulla. The cortex produces cortisol, aldosterone, and androgens. What do we call androgens? Sex hormones. You want me to tell you something funny? Andro, what does andro mean? What does andro mean? I'm gonna show you that your medicine and the things we are studied in medical school is very connected to life. I'm gonna prove that to you. Now, what's andro mean? In Greece or in whatever? Yes, Mustafa. Andro means man. And the word android, android. And when we say oid, carcinoid, oid means small. When we say android, that means small man. Look at the image of the android. Do you see? Android. The word android means like small man. Okay? The android show.
It's from Greek, yeah?
Yeah, from Greek. So andro means man. Androgens mean production of the hormones that will differentiate the man from the woman, which is sex hormones. Medulla produces adrenaline, epinephrine, noradrenaline, norepinephrine. Okay? Okay. Here you have zona glomerulosa, zona fasciculata, and zona reticularis. This is not the adrenal gland. This arrow was supposed to be for all of these guys. All of this is adrenal gland. Okay, all of this is adrenal gland. Okay, here this should be the medulla down there. So this image I need to correct it, man. It's not that accurate. I just want this is the zona glomerulosa, zona fasciculata, and then reticularis. Here you have the medulla. I hope you understand that. All right. Zona glomerulosa produces the aldosterone, which affects the salt. Zona fasciculata produces the cortisol, which affects the blood sugar. And zona reticularis will produce the androgens, which will affect the sex hormones. So here, zona glomerulosa produces aldosterone, zona fasciculata produces the cortisol, and zona reticularis produces the androgen. Does anyone remember the mnemonic for that? How to memorize them? Let me give you a hint. It will get sweeter once you get deeper. Have you remember that? طبعا هي mnemonic قلة أدب لكن you will understand with it. Does anyone know that mnemonic? Okay, let me show you then. So zona glomerulosa produces aldosterone, which affect the salt. Zona fasciculata produces the cortisol, which affect the sugar. And zona reticularis will produce the androgen, which will affect the sex. So this is very superficial glomerulosa here. And this fasciculata and this reticularis. And this is very deep. So mnemonic it gets sweeter when you move deeper. Okay, so when you go from the superficial, you go from salt to sugar to the last one, sex. دي تاني ما حتطلع من راسكم. Okay, give me thumbs up if you understand it. ما دار اكون بتكلم ساي وانتم ما فاهميني. Let me just change the image. Fine. Okay. Let me just cortex of ترى لعبت عليها شديد لكن ما كانت accurate. Fantastic. Let me just take it out. I don't want anything that's not accurate. Okay, so when you go deeper, when you go from here, when you go deeper, it gets sweeter. Aldosterone salt, fasciculata sugar, cortisol meaning, and then reticularis sex hormone. Okay, here's another image for each of them and most common diseases. Okay, zona glomerulosa, aldosterone, one control of renin and angiotensin system. Cone syndrome is increase in aldosterone. Primary cone syndrome has low renin, while secondary cone syndrome has higher renin. Meaning, they may ask you, they may tell you your patient has high aldosterone and your patient has high renin. In that case, that means it's not a primary cone syndrome, it's secondary cone syndrome. Because if it was a primary cone syndrome, the high aldosterone will suppress the renin and will make it low. Same idea of the same principle of the thyroid we just mentioned, the difference between primary and secondary hyperthyroidism. All right, zona fasciculata, cortisol, one control of ACH, on control of ACH, meaning the ACH control the cortisol in the zona fasciculata, shows circadian rhythm. That means high in the morning and low in the evening. That's why when you start working in the hospital or when you practice, you will take, we have a test, we call it 9 a.m. cortisol. Okay, we don't take cortisol anytime. We have a specific time to take the cortisol. Why? Because it's follow the circadian rhythm. Cushing syndrome, meaning there will be high cortisol. Primary Cushing has low ACTH, meaning the primary Cushing syndrome, the issue is in the zona fasciculata. The zona fasciculata producing too much cortisol. When you have too much cortisol, this will go and suppress the anterior pituitary and prevent it from producing ACTH. That's why the primary one, they will be low ACTH. Secondary Cushing syndrome, they will be high ACTH, meaning the problem will be from the pituitary, anterior pituitary. The anterior pituitary producing a lot of ACTH, and a lot of ACTH is activating the zona fasciculata, producing more cortisol. Zona reticularis, sex hormone, as we said, on control of ACTH also. Adrenogenital syndrome due to increased adrenal sex hormone by ACH due to decreased cortisol by 21-hydroxylase enzyme. We'll come. So adrenogenital syndrome, we'll speak about that in the pathology. Okay, it's a very complicated syndrome. I will explain in detail in the pathology. If you wanna understand the idea of it, there will be increase in adrenal sex hormone. All right, because there will be increase in ACTH. Why? Because there is a reduction in cortisol. Why? Because you have a deficiency in an enzyme called 21-hydroxylase enzyme. The question in your exam will be, what enzyme is missing? And the answer is 21-hydroxylase enzyme. So defect in 21-hydroxylase enzyme will lead to adrenogenital syndrome. Okay? Adrenal medulla produces catecholamine. Sympathetic fiber release acetylcholine to stimulate adrenal medulla to secrete adrenaline mainly and some noradrenaline. So think about it. You have sympathetic and parasympathetic. Sympathetic adrenaline and noradrenaline. Parasympathetic is acetylcholine. This is such a unique case. The adrenal gland will be activated by the sympathetic fiber, which will produce acetylcholine, and the acetylcholine will reach the medulla and activate the medulla to produce catecholamine. All the sympathetic effect happen through norepinephrine and epinephrine, except two organs, adrenal gland and sweat gland. The effect of adrenal gland and sweat gland, both of them, is through acetylcholine. We're talking about the sympathetic system, which is very unique and not usual. Pheochromocytoma, very high yield. You will have a question about it. We'll come to this in the pathology also. Catecholamine in attack due to tumor of the chromaffin cell of the adrenal medulla. So basically, I will tell you all what you need to know about the pheochromocytoma in just 1 minute. Pheochromocytoma, increase of epinephrine and norepinephrine. Your patient will come with high blood pressure and transient tachycardia. Okay? You will check the catecholamine, you will find it high in urine or in serum. It's very crucial to diagnose it, because if your patient is going to surgery, or if your patient have hyperthyroidism and you want to take the thyroid, you may lead to thyroid storm. If your patient has pheochromocytoma and you're doing thyroidectomy, you need to give them beta blocker. Why? Because beta blocker will prevent or reduce the effect of the adrenaline and noradrenaline, and it will also reduce, beta blocker will reduce the transmission from T4 to T3, which is the active form. That's all what you need to know about pheochromocytoma, and we'll speak about it in the pathology when we come to the pathology. Okay. Addison crisis, very also high yield. Acute adrenal crisis, life-threatening acute adrenal insufficiency caused by sudden severe deficiency of cortisol and sometimes aldosterone, leading to cardiovascular collapse and metabolic disturbance. That's why we tell every single lady not to take steroids. Because if you take steroids, what will happen? You will be dependent on it. Meaning, your pituitary gland will stop producing ACTH. And when your pituitary gland stop producing ACTH, because you have a lot of cortisol, you have a lot of steroid in your body, your pituitary gland stop to produce ACTH, your adrenal gland will start not working. if you stop the cortisol. And when it start not working, you won't have any aldosterone. And aldosterone is very important for you to control your blood pressure. Okay? And that's why will happen the collapse. Okay. Let me just complete what we started. All right. Causes. Stress precipitating adrenal failure due to, it could be due to sepsis, major surgery, or severe illness or trauma. And also abrupt stop, abrupt discontinuation of steroids. Okay. Yeah, it's sorry, written here, sorry, so we don't need to write that one. Okay, so I just subclassified the causes. Okay, so stress precipitating adrenal failure, meaning if your patient has sepsis. Why sepsis will cause adrenal issue? When you have sepsis, you have vasodilation, and this vasodilation will lead to drop in the blood pressure. If your patient has sepsis, that means the blood pressure is very low. When the blood pressure is very low, the blood supply to the adrenal gland is very low, and this will lead to, we said earlier, if you remember, if you can connect the information, we said the medulla has just 2% of the blood supply of your body. 98% is going to the cortex for the adrenal gland. So if you have sepsis and you have low blood pressure, that means the blood supply to the medulla is even less. And this will lead to sepsis. This will lead to necrosis of the medulla. So sepsis, major surgery, and severe illness or trauma. Adrenal destruction or hemorrhage. Adrenal hemorrhage, for example, Waterhouse Friderichsen syndrome. This is very high yield syndrome. Basically, they will tell you there's a baby coming with non-blanching petechiae. He will have a skin lesion all over his body. It will be in the summer. He was in the school. He has severe headache and neck irritation or neck stiffness. And then suddenly he collapsed. That's Water-Friderichsen syndrome. Occurs in fulminant meningocemia, meningitis basically, causes bilateral adrenal hemorrhage. Okay, this syndrome is very high yield. Then we have drug-related sudden steroid withdrawal. Long-term steroid uses suppress the hypothalamic pituitary adrenal axis. So if you have hypothalamic pituitary adrenal axis, if you're taking steroids for a long time and you suddenly stopped it, that's mean, okay, your adrenal gland used to ACTH to activate it. Your adrenal gland used to ACTH to activate it. This gland always waiting for ACTH coming from the anterior pituitary to activate it. You take steroids. Your body thinks you have enough steroids in your body. ACTH stop working. Stop coming from the pituitary. Okay? Because you're taking the steroid. And suddenly you stop. Your body still thinks you have a lot of steroid. The ACTH is still not coming. That means the adrenal gland will be useless and it will not be working. Okay? That's the main idea. For your life and for your exam. Okay? For your life and for your exam. Yeah, let me just investigation. Yeah, let's speak about it in more details. So how the adrenal crisis will happen? Your patient will have hypotension, hypoglycemia, and pigmentation. Why? Hypotension, there's no aldosterone. Hypoglycemia, there's no cortisol. There's pigmentation due to increased ACTH. Additional common finding: weakness, vomiting, abdominal pain, dehydration, and confusion and collapse. If you have a young lady coming with weird symptoms and she tells you, every time I measure my blood pressure is low, think about that one. Addisonian crisis is 3H: hypotension, hypoglycemia, and we should give hydrocortisone 10 milligram IV. I just created this mnemonic for you to make you memorize what's really important. Okay, what investigation we can do? Yes, prednisolone, fantastic. ACTH testing used to distinguish primary Addison disease from secondary Addison disease. Okay. What do you mean by primary Addison disease? Primary Addison disease means the problem in the adrenal gland. Secondary Addison disease, the problem in the pituitary gland. If you measured the ACTH and you found it high, that means the problem in the adrenal gland. The adrenal gland is not working, and the pituitary is producing a lot of ACTH to activate the adrenal gland. Secondary Addison disease means that the pituitary is not producing ACTH from the start to begin with. That's why your adrenal gland is not working. All right. We have also what we call Shorsen-Castain test. Based on, we measure the baseline serum cortisol. Firstly, we take a blood sample, measure the baseline serum cortisol. Then we give the patient ACTH, synthetic ACTH, we call it synactin. And then we measure cortisol afterward. So we take the cortisol first, we give ACTH, and we measure it afterward. If the baseline was 9, let's say, and we gave the thincastin, and after that became 9, became like the normal ratio. If it became normal, that means the cortisol for the normal person who has no problem, the cortisol will rise directly after we give the ACTH, which makes sense because when you give ACTH, it will go to the adrenal gland and will activate the cortisol. If you have primary adrenal insufficiency, meaning if the adrenal is not working from the start to begin with, whatever you give ACTH is not working. لو عندك مصنع والمصنع خسران وواقف ومعطل وجبت كمية من العمال، هل المصنع حيشتغل؟ ما حيشتغل. If you give a lot of ACTH while the adrenal gland is destroyed from the start to begin with, that means it won't work. Okay? Okay? Treatment. Prevention and prophylaxis. Patient with adrenal insufficiency undergoing surgery requires stress dose steroid, gives cortisol induction, continue post-operatively for several days. So basically, if the patient is taking a steroid, before you take him to the surgery, you give him a lot of hydrocortisone. 10 milligram IV hydrocortisone immediately. Okay? And then you give IV fluid and correct hypoglycemia, as you know. Okay. Pancreas gland, last one. It's going to be quick, hopefully. So I want you to know, we're speaking about the pancreas as endocrine here. Beta cell produces insulin in Langerhans Island. Alpha cell produces glucagon. Pancreatic polypeptide from F cell, and delta cell produces somatostatin. Effect of insulin, metabolic effect, carbohydrate metabolism, increase glucose uptake into tissue, increase glycolysis, and lead to decreased blood glucose. Glycogen metabolism, stimulate glycogen formation in the liver, muscle, and adipose tissue. Electrolyte effect, we said it decreased blood potassium level by taking the potassium from outside into the cell. And that's why we use insulin in the treatment of hyperkalemia. Then it has effect on fat and protein metabolism, increase lipid synthesis, increase protein synthesis. Insulin half-life is 30 minutes. Okay, here image just showing you the effect in a table. No, in just an image, exactly what we said above. Diabetes mellitus type 1 account for 10%. Destruction of beta cell of the pancreas may be due to autoimmune disease, lead to deficiency of insulin secretion, usually occur in children and young adult. Patients are usually lean, more prone to diabetic ketoacidosis. Treatment, take insulin. Then there's a new trend of, not taking insulin and نظام الطيبات. That's wrong. Type 2 diabetes account for 90% due to abnormal insulin resistance at the site of action. Usually occurs in adult, commonly associated with obesity. Less common cause of DKA. Okay? All right. How we treat it? How we diagnose it first? Fasting plasma glucose. Patient fast for at least 8 hours, and then you check the glucose. If it's more than 7 millimole per liter, that's diabetes. Oral glucose tolerance test. Measure glucose 2 hours after glucose load. You give your patient, I think it's 500 gram, or you give him a specific amount of glucose, and then you measure it immediately 2 hours later. If it's more than 11 millimole per liter, that's a diagnosis. Hemoglobin A1C, important modern guideline point, very important now. Hemoglobin A1C, if it's more or equal to 448 millimole, that's meaning 6.5%, that's diagnostic for diabetes. Random blood glucose, you need it to be more than 11.1 millimole plus some symptom to suggest diabetes. Because if you ate a lot of cake now, and I just measured it, and it's not that high, that means there is no issue. Okay? Stress response of hormone, this is very high yield for your exam. Stress response on hormone, even in your surgery or just stress response. Stress response will increase GH, prolactin, ADH, cortisol, renin, and glucagon. Very important for your exam. Very, 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 very important. Decrease testosterone, insulin, and estrogen. No change FSH, LH, and TSH. How you remember that there's no change in FSH, LH, and TSH? Do you want me to give you stupid mnemonic? Do you want me to give you stupid mnemonic for that? You remember it by saying my himinish. My himinish. My himinish.
Again, I didn't hear it. Sorry.
My himinish. My himinish.
FSHLH. Nice.
Uh, all right. I'm just trying to find a way. So, yeah. Usually they will try to trap you by this one, by giving you a hormone from here, okay? Okay, paraneoplastic syndrome, we'll speak about this a lot. I want you to know that Cushing syndrome is associated with small cell lung cancer. That means small cell lung cancer produces ACTH-like hormone. Siyada syndrome, syndrome of inappropriate antidiuretic hormone associated with small cell lung cancer too. Hypercalcemia associated with squamous cell cancer. How you remember that? Hypercalcemia, squamous. So I want you to think about calcium, and I want you to associate that with key. Sorry. Okay. And acanthosis nigricans with gastric cancer and polycythemia with renal cell cancer. This is very high yield. So this table and the other one. Okay. And by that, we finish the session for today. All right, 2 hours. Wow, man. It's 2.5 hours. Mustafa, we started 7:30, didn't we? We started 7:30, right? والله انتوا
Yes, like
صبورين. والله ما انتوا صبورين ولا انا معاط. لكن I have to reduce the amount of the lecture, man. It's too much. Yeah, this is too much. We have to reduce the time, by the way. We have to make it maximum 1 hour and a half. Okay. Any question, drop it in the community, okay? I'm not gonna continue more. Any question in the community? يلا يا جماعة. We finished. Go enjoy your day.